I would like to welcome you all to this review of the PEPPER for home health agencies. My name is Annie Barnaby, and I work for the RELY Group. RELY Group is contracted with the Centers for Medicare and Medicaid Services, or CMS, to develop, produce, and disseminate the PEPPERs. For those of you who might be interested in live captioning of today's session, you can access the captioning by clicking on the link that is in the QA panel. It's the very first question listed. Today I will be focusing on the most recent release of the PEPPER for home health agencies. This is for the fourth quarter calendar year CY20. In this release, there are some target areas that we will discuss, and we'll talk about how each of those target areas are calculated. We'll look at a sample PEPPER, and we'll review some other resources that you might find helpful, and which include the peer group bar charts, and all of those resources are available on our homepage. Today's presentation will be a high-level review of the PEPPER, so if you're familiar with PEPPER, this will be a nice refresher. But if you're new to PEPPER, you might still have questions at the end of the session, and we have resources available to you to help if you do have questions. These resources can be accessed through the PEPPER website in the Home Health Agency Training and Resources section. Our website is, of course, pepper.cbrpepper.org. Let's start at the very beginning. What is PEPPER? Well, PEPPER is an acronym that stands for Program for Evaluating Payment Patterns Electronic Reports. And a PEPPER is a comparative report that summarizes one hospital's Medicare claims data statistics for areas that may be at risk for improper Medicare payments, primarily in terms of whether the claim was paid correctly, the claim was correctly coded and billed, and whether the treatment provided to the patient was necessary and in accordance with Medicare payment policy. In the PEPPER, these areas that might be at risk are called target areas. The PEPPER summarizes your facility's Medicare claims data statistics for these target areas and compares your statistics with aggregate Medicare data of other facilities in 3 different comparison groups. Those comparison groups are all home health agencies in the nation, all home health agencies that are in your Medicare Administrative Contractor or MAC jurisdiction, and all home health agencies that are in your state. These comparisons are the first step in helping to identify where your claims could be at a higher risk for improper Medicare payments, which in the PEPPER world means that your billing practices are different from most other providers in the comparison group. I do want to stress that the PEPPER cannot identify improper payments. The PEPPER is a summary of your claims data and can help you identify or alert you if your statistics look unusual as compared to your peers, but improper payments can only be confirmed through a review of the documentation in the medical record along with the claim form. Taking a look at the history of the PEPPER, we can see that the program began back in 2003. TMF Health Quality Institute developed the program originally for short-term acute care hospitals and later for long-term acute care hospitals. In 2010, TMF began distributing PEPPERs to all providers in the nation, and along the way they developed PEPPERs for other provider types, which you can see on this slide here. Each of these PEPPERs is customized to the individual provider type with the target areas that are applicable to each setting. Then in 2018, CMS combined the Comparative Billing Report, or CBR, and the PEPPER programs into one contract, And the Rely Group and its partners, TMF and CGS, now produce CBRs and peppers. While the CBR program produces reports that summarize Medicare Part B claims data, the peppers summarize Medicare Part A claims data. These reports are produced for providers across the spectrum that help educate and alert providers to areas that are prone to improper Medicare payments. So why does CMS feel that these reports are valuable and support their agency goals? CMS is mandated by law to protect the trust fund from fraud, waste, and abuse, and they employ several strategies to meet this goal, such as data analysis activities, provider education, and early detection through medical review, which might be conducted by the Medicare administrative contractor, a recovery auditor, or some other federal contractor. The provision of peppers to providers supports these strategies. The pepper is considered an educational tool that can help providers identify where they could be at a higher risk for improper payments. The providers can proactively monitor and take preventative measures if necessary. I should also mention that the Office of Inspector General, or OIG, encourages providers to have a compliance program in place to help protect their operations from fraud and abuse. An important piece of a compliance program is conducting regular audits to ensure that charges for Medicare services are correctly documented and billed, and that those services are reasonable and necessary. The PEPPER supports that auditing and monitoring component of a compliance program. Let's focus now on the PEPPER for home health agencies. This newest release was made available in July of this year. This release summarizes statistics for 3 calendar years. We're looking at calendar years 2018, 2019, and 2020. And the reason that we call this version Q4 CY20 is because the report summarizes statistics through the 4th quarter of calendar year 2020. Now, those of you who are familiar with Pepper know that each time we produce a new report, we refresh the statistics for all time periods and all target areas. So it is certainly possible that if you are looking at your new Pepper and comparing it with the Pepper that you received last year, you might see some slight changes in numerator or denominator counts, or maybe the national or state or jurisdiction percentile values. And that would be expected because the refreshed statistics are going to reflect any corrected claims that might have been submitted, any late claims, those types of things. So there will probably be, or there may be, some slight differences in those numerator and denominator counts. And each time we produce a Pepper, the oldest calendar year rolls off as we add the new one on. Let's move on now to focus on the improper payment risks that are pertinent to home health agencies. Now, prior to January 1st, 2020, home health agencies were reimbursed through the Home Health PPS, or Prospective Payment System, which paid higher rates for services to beneficiaries that have greater needs. Payments were based on a 60-day episode payment. This reimbursement structure has been changed under the patient-driven grouping model, the PDGM. The PDGM model has a 30-day payment period. The previous home health PPS had been identified as at risk for improper Medicare payments. In particular, over the past few years, those of you who keep track of the improper payment report know that it is produced by the Comprehensive Error Rate Testing, or CERT contractor. Know that the most recent estimate for 2019 was that 12.1% of home health claims were found to be in error, resulting in a projected improper payment rate of over $2.3 billion. So this high level of projected improper payments probably played a part in the transition to this new payment model. Prior target areas were developed based on a review of the home health PPS and with a focus on those areas that could be at a higher risk for improper Medicare payments. After reviewing studies that were related to improper Medicare payments, national level claims data, and an OIG report from 2012 that identified 6 measures of questionable billing, we worked in coordination with CMS subject matter experts to create the current target areas. I also want to mention that all target areas are evaluated on an annual basis and can change over time as we continue to assess the home health improper payment risk. The patient-driven grouping model, PDGM, went into effect at the beginning of 2020, and our team coordinated with CMS to adjust the PEPPER accordingly. This PEPPER version Q4 CY20 is the first release to reflect the PDGM statistics and the modifications that were made to the PEPPER. CMS has developed many resources for providers related to the PDGM, and you can find them on the CMS website through the link that is linked on this slide. The target areas in the HHA PEPPER were created according to the potential risk for Medicare payments and are calculated using a numerator and denominator. The numerator represents the episodes or payments or other measures that might be potentially problematic, and the denominator is a larger group. Now, in the home health, we have 2 different types of results. Some target areas have a result that is a rate, and these target areas are calculated with a calculation where the numerator and the denominator are different units of measure. Some of the target areas are reported as a percent. In this calculation, the numerator and denominator are reported or measured using the same units, and the numerator is a subset of the denominator. So here you can see some of the HHA PEPPER target areas. This is the beginning of the list here. We start with low comorbidity. This one is a new target area that is new as of this release. High comorbidity, again, this is a new one as of the Q4 CY20 release. Average number of periods. You can see that average number of periods is, of course, reported as a rate, not a percent. Average case mix. Periods with low visits. That one is, again, revised. It's not completely new. It is revised as of this release. Non-LUPA payments, outlier payments, admission source, again, that's a new one. That admission source is a new one for this Q4 CY20 release. So that is a list of the target areas, and we'll see how those are listed and defined in the actual PEPPER as well. So we've talked a little bit about percentiles. So how do the percentiles work within the PEPPER? Well, this slide can help us to understand how the percentiles are calculated. The ladder image is a great representation of how we do that. Next to the ladder is a list of the target area percents sorted from highest to lowest. The first step our team takes when we calculate your HHA percentile is to take all of these target area percents for a target area and a time period. We take the target area percents for all of the home health agencies in the nation, and we identify the point below which 80% of those home health agencies fall. And that point is identified as the 80th percentile. So any hospitals that have a target area percent that is at or above the national 80th percentile will be identified in the PEPPER as a high outlier. A high outlier is identified in the PEPPER target area tab data by red bold font. A high outlier outcome could potentially mean overcoding, or it could just mean that your statistics look different for another justifiable reason. Before we review a PEPPER, let's review the comparison groups. On this slide, the visual reminds you that we do have these three comparison groups: nation, jurisdiction, and state. Sometimes the MAC jurisdiction comparison group is confusing to people, so to simplify, think about it as being comprised by all of the providers that submit their claims to the same MAC. Those are the providers in the MAC jurisdiction comparison group. And that is a way of giving us a smaller group to compare with than the nation and a larger group than with the state. I'm going to go to our sample pepper now so we can see an actual document of how all of this data is presented. All right, so you can see on the screen the Microsoft Excel workbook that the pepper is presented in. And you can see down on the bottom here these different tabs for each of the target areas, and then for some other information as well. For instance, this first tab is the purpose tab. It shows us what pepper we're looking at, the Home Health Agency pepper for the most recent 3 calendar years. You can see through Q4 CY 2020. Tells you a little bit about pepper. It tells you, again, the pepper version that you're looking at, the jurisdiction that your home health agency falls under. And then next to that tab, the second tab is the definitions tab. So as we were clicking through those slides that had information for each of these target areas, we saw the definition and how each of those target areas was calculated. This definitions tab has all that information for you listed here. And it does mark those new target areas that we have within this Q4 CY20 pepper. But as I said, it also has these definitions. What goes into the numerator? What goes into the denominator? Which of these are reported as a rate? Which are reported as a percent? So if you're going through your pepper and you're looking at your data and you're wondering, well, wait a minute, what did this numerator represent? I forget. So it's right there for you, just in that second tab. And so this is a really a very beneficial tab and data set, or information set, I should say, within the pepper, because again, it does tell you exactly what you're looking at when you get into those target area tabs. So this is the Compare Targets report. And this is going to show statistics for target areas that have reportable data. Now, when we're talking about reportable data, we are talking about 11 or more target discharges in the most recent time period. So if that numerator or denominator does not have 11 plus in that numerator or denominator, then that is not going to be considered for the pepper. That's just the minimum threshold that we've placed to make the pepper as beneficial and efficient as possible. So you can see in the description at the top here, if an agency's jurisdiction is 80%, 80% of the agencies in the MAC comparison group have a lower percent value than that agency. And then the state and the nation are displayed in the same manner. So this kind of just gives you a roundabout of, again, more general information about your reportable data for each of those target areas. And then as we move forward in the tabs, we start in with each of the target areas. So our first target area that we have here is a low comorbidity. Now, as this was new, as of this release, Q4CY20, you can see that obviously for the calendar years 2018 and 2019, there is no comparative data. It didn't exist until the calendar year 2020. But you can see now these tabs are for your individual target area and your individual home health agency. So the target area percent for this sample provider was 44.4%. And then it breaks it down for you. And I'm working from the top down here. We have your target count and then your denominator count. So not only does it give you your percent value for your outcome, but it also gives you that numerator and denominator of how we calculated it, how that percentage was calculated. So the target average length of stay, so the average length of stay for that numerator, and then the average length of stay for the denominator, those are also listed for your reference. And then the average payment and the sum of payments is listed again. So again, it really breaks everything down really in a detailed fashion so that you can take a look at everything that is going into these calculations. And you can take a look at, again, where you fare according to where you fall on that ladder. We listed those target area percents, these outcomes, and remember, in highest to lowest order on that ladder. And we drew that line below which 80% of the HHA outcomes fell. Now, this sample provider has an outlier of 44.4%. As we discussed before, if you are a high outlier, if you are in that 80th percentile, then the outcome is going to be written in red bold font, which you can see here it is. So this is just another way that information, that data kind of jumps out at you. Again, it's listed here as well, the outlier status, high outlier. It's in red bold font so that you can see. And then down here, it shows you in the comparative data, the national 80th percentile. Where did that line go through on that ladder? What outcome was listed on that line when it was drawn? So we could separate those 80% of where those providers fell. And that was at 42.3%. So as you can see, of course, 44.4 is higher than that. So this provider's outcome fell above that black line. So we have each individual information up here. Then we have the national, state, and jurisdiction information down here. Everything that you could possibly need for each of these target areas is on each of these tabs. So it's really incredible that this is such a detailed free report that everyone can use, that your agencies can use to see your numbers coming in and then where you fall as compared to your peers and those other health agencies in the nation, state, and jurisdiction. So again, we can see that year 1 and year 2, everyone was at 0 because this target area did not exist. But you can see also here that these are these comparison data points are listed here. So we can see the jurisdiction, or excuse me, the national percentile is this straight line. The jurisdiction is this green dotted line or dashed line, I guess. And then what do we have? We have our high outlier. So we can see this blue part is the home health agency that we're looking at, this individual home health agency for this sample agency. It's at 44.4%. You can see that just barely clears this national 80th percentile mark, which was at 42.94, which is basically 42.3%. So you get all the information in those 3 sections. You get it in a chart for your individual, you get it in a chart for your comparative data, and then you get it in this graph. If that's easier for you to review, especially maybe at a quick glance, you know, that's there for you as well. So not only do we provide all of this information, but we also have suggested interventions. What should you do if you are above that 80th percentile? What should you do if you're below the 20th percentile? That 20th percentile would be, we draw that other black line through that ladder, and whoever falls below that 20th percentile would be indicated as such. So again, we give you the data, but then we also say, hey, it's suggested that perhaps you might want to take a look at this. You might want to review this. These are some changes that potentially could be made. So let's move. I'm not going to go through each of the target areas in detail, but I will say let's go to high comorbidity. We can see, again, this was a new one for this release, so there's no data for 2018 or 2019. And it's the same layout, the same information. All right, average case mix. Let's take a look at this one in a little bit more detail because this one is not new. So we do have information for all of the 3 years. It looks like this sample agency was not an outlier in 2018 or 2019, but they were a high outlier in 2020. Another reason to take a closer look maybe at this calculation in this target area is that this is calculated as a rate instead of a percentile. So those data points that are listed down that ladder image are all rates and not percentiles. So you can see here the target area rate, the target count, your denominator count, the denominator average length of stay. So, and again, you can see the national, jurisdiction, and state rates listed here. And again, we're a high outlier, so we're in bold 1.24 up here. And this will show you the outline of, again, all 3 of those years in this graph. So we have the home health agency, their data points are in this bar graph. And then the jurisdiction, nation, and state 80th percentile are listed with these line graphs. And again, you can see this bar graph just barely clears that jurisdiction 80th percentile. It clears all of them, but that jurisdiction is the highest one, just really close to this agency's outlier status, or excuse me, outcome status, which is 1.24. You can see that jurisdiction was only at 1.22. And again, as I said, I'm not going to go through each one individually because that would be very dry and a little boring for all of us. But of course, if you have any questions calculating or looking at your PEPPER, feel free to reach out to our help desk. But as I said, the PEPPER really does have all the information that you could ever possibly need. If you get mixed up as to what you're looking at on each of these tabs, you can always go back to this definitions tab, take a look, and be reminded as to what you're looking at. So for this average number of periods, this agency, the sample agency, was not an outlier in any of the 3 years. Periods with low visits, this agency was a high outlier in the first 2 years, and then they dropped way down in calendar year 2020, and they are no longer an outlier. And it looks like the nation, the jurisdiction, and the state did drop down as well. But this is a good sign. Again, perhaps this agency took heed to the suggested interventions when they were looking at their past PEPPERs and taking a look at their outlier status, their high outlier status, and they made some adjustments. And that's what the PEPPER is here for. It's to help you internally look at where you fall as compared to your peers. Okay, for the non-LUPO payments, again, this agency was not an outlier for any of those 3 years. in outlier payments, not an outlier. This agency was under 1% for all 3 years, and you can see the national, jurisdiction, and state were all at least above 2%. So obviously this agency would not be an outlier for any of those comparisons. The admission source is new this year, so we only have 2020 information. And this agency, again, is a high outlier for this new target area. So what are they going to do? They're going to use that internally. They're going to take a look at their numbers, and they're going to see how maybe they can make some adjustments so that next year when they get their PEPPER, they are no longer a high outlier. All right, this tab, we're getting away from moving on from the target areas. In this next tab, the top clinical groups. Basically, it's pretty self-explanatory, but these are the top clinical groups that were reported in the PEPPER data. So you can see here information for all of these clinical groups, total periods, proportion of periods for the clinical group to the total periods. I mean, this is all, again, all the data, all the calculations, so that you can take a step back and see, all right, aside from myself, what were those 19 top clinical groups for this past calendar year? And then this is the same thing, the top clinical groups for the jurisdiction. So back here, we were top in the nation, and then this is for your jurisdiction. And again, that's kind of a nice middle ground for comparisons. When we're talking about the jurisdiction, it's bigger than the state, but smaller than the nation. So it's a good comparison group in the middle there. So those are all the tabs for this PEPPER, for the Home Health Agency PEPPER. Again, there is a lot of information on there. Please don't let that overwhelm you when you get your PEPPER. If you break it down and look tab by tab, it is much more digestible that way, and you can use that information to your benefit. Great. Well, how does PEPPER apply to providers? Well, the PEPPER can help a facility, again, to identify areas where they may be outliers, and if that outlier status is something that should prompt an internal review within each of the target areas. We often get the questions, do I have to use my PEPPER, and do I need to take any action in response to my PEPPER? The answers to these questions is no. You're not required to use your PEPPER, though it's helpful information, and we would encourage you to at least download it and take a look, but you're not required to take any action. However, it is important to remember that other federal contractors are also looking through the entire Medicare claims database. They might be looking for providers that could benefit from some focused education or maybe even a record review. And again, from your perspective, it would be nice to know if your statistics look different from others, so then you can decide if there's something to be concerned about and if you need to take a closer look, or if what you're looking at is what you would expect to see in your PEPPER. As we saw, the PEPPERs are distributed in electronic format in a Microsoft Excel workbook, and they are available for 2 years from the original release date. We cannot send PEPPER through email because of the sensitive data housed within the PEPPER. We have to be judicial in the way that we distribute the PEPPER, and it cannot be sent through unsecured email. With that in mind, we do have a portal online that you can use to access your PEPPER, and we encourage you to go to the portal and download your PEPPER so that you can have it in your files for your use. There are specific people who are authorized to receive the PEPPER. We don't give access to just anyone. We only release a provider's PEPPER to that specific provider, which is why we have the portal and the specific validation code requirements, so that not just anyone can come to the website and get your PEPPER. The PEPPERs are not available for public release, and we do not provide PEPPERs to other contractors. But we do prepare Medicare Access Database, which is called Fathom, and we make that available to Medicare administrative contractors and to recovery auditors. And the Fathom can be used to produce the PEPPERs. Now, while that might sound a little scary to some people, I want to point out and that it is important to remember that federal contractors have access to much more claims data information about providers than what is included in your PEPPER. And they may also have access to sophisticated data mining tools and other materials that may assist them with their efforts. I should also point out that law enforcement, such as the Department of Justice or the Office of Inspector General, may be able to obtain your PEPPER in an effort to support their internal activities. Again, now while all of that might sound alarming, remember that the benefit of the PEPPER is that you will have an opportunity to have a heads up in the case that your billing patterns might look unusual. And then you can prepare if there should be regulatory or law enforcement agencies that contact you. Let's look in detail now about how to access your PEPPER. When you access your PEPPER, you will be asked to enter some data and information. So in preparation to go to the portal to get your PEPPER, you'll need to have your 6-digit CMS certification number. This is also sometimes referred to as the provider number or PTAN, and this is not the same as your tax ID or your NPI number. So validation codes are also emailed to the contact listed for each facility in the provider enrollment chain and ownership system, PACOS. And the validation codes that are sent are updated every year. So if you have an access code, a validation code from a prior release, you're not going to be able to use that. That's not going to be valid or accepted for this new release. Let me go, before we start this slide, let me go to the PEPPER portal. And while I'm going there, I would encourage everyone, if you have a question, please, again, use that Q&A panel so that we can see your question and respond accordingly. That is the only panel that we look at during these presentations. All right, so we're looking at the PEPPER portal now. And this is where you'll go to download your PEPPER. So as we said before, we do have some information that you're going to need to input. You have your information, first name, last name, the provider name, where they're located. Again, here's your CMS number. So depending on the provider type, you can either enter the validation code. As I mentioned, it was sent to, or it is sent to the contact on file in the PACOS system. So you can enter that, or you may be able to enter a patient control number. And we do have detailed instructions. I'm just going to click here so that we can see, make sure I'm sharing it correct. Yes, okay. So this is the distribution center, and it has information right here for home health agencies. You can click on the portal access instructions, and it spells it out for you there. So you'll either be able to enter a validation code, again, sent to the provider enrollment chain and ownership system, the PACOS contact that is listed for the home health agency, or you could enter a patient control number that's found at form locator 03A on the UB04 claim form, or a medical record number, which is found at locator 03B. And this is going to be for a traditional Medicare Part A fee-for-service patient. And that patient had to have received services from October 1st, 2020 through December 30th, 2020. So that end part of the calendar year 2020, which of course is what we're looking at in this PEPPER release. So if you are not the PACOS contact, or you are having trouble figuring out who that PACOS contact is to get the validation code, you can use information internally from either that patient control number or the medical record number. And down at the bottom, we do ask that the user certify the position that they are in within the home health agency. However, I do want to point out down here that if the provider, if that basically means if the person trying to get into the portal does not have a management title with any of these titles, the person who has the authority to make the decisions on behalf of the organization should click the box that best describes their position. So I don't want anyone to, halt their access process when they see this. If you have the authority through your HHA to download this PEPPER, you've been asked to do so, you have that authority internally, but you do not hold one of these titles that's listed here, as the instructions say, just click on the title that best matches your title. So don't let that stop you from downloading your PEPPER. All right, let's talk about some strategies. If you get your PEPPER and you see a lot of red indicating that you are a high outlier, please don't panic. Remember that just because you're an outlier in your PEPPER, it doesn't mean that any compliance issues exist, and it doesn't mean that you're doing anything wrong. But again, we encourage you to think about why you might be an outlier for those statistics in your PEPPER. Do those statistics reflect what you expect to see? If something doesn't feel quite right, coordinate with others within your agency, share the PEPPER information as appropriate, put your heads together and think about some factors that may be affecting these numbers. Pull some records and some claims just to evaluate and make sure that you're following those best practices. We have a number of other resources that are available publicly on our website, which is pepper.cbrpepper.org. One of those resources is aggregate information for the target areas, both at a national and state level. Also, aggregate information regarding the top diagnosis, top therapy episodes, and this information is updated each time we have a PEPPER release. Mentioned in our agenda today that we also have peer group bar charts, which are updated on an annual basis. Some time ago, we did have providers who had asked us to make available a comparison that would be applicable to what they would consider their peer group. And so those peer group bar charts enable providers to look at that type of information. We have 4 different categories. We look at location, so that would either be urban or rural, ownership type, for-profit or physician-owned, nonprofit or church-owned, or government teaching status and surgical focus. And we do update the peer group bar charts annually. If you find that you do not agree with how we are representing your agency's ownership type or location, that information will need to be updated through CMS. We utilize the CMS Provider of Services file, and that's maintained by the CMS regional offices. So you'll need to contact them for that update. This is an example of a peer group bar chart that shows us what these charts look like. This chart is for outlier payments, how the 20th, 50th, and 80th percentiles can differ based on urban or rural location. We can see that the urban agencies have a much higher 80th percentile and a somewhat higher 50th percentile than the rural agencies do. And a number of other resources can be found on the PEPPER website. Of course, there's the user guide, the PEPPER training sessions, a demonstration PEPPER, a spreadsheet that will identify the number of agencies in each of those max jurisdictions in total and by state. And there are some testimonials and success stories. There are some really nice success stories out there, one in particular from a Kentucky hospital that used their pepper to help them identify undercoding. As always, if you need assistance with Pepper and do not find the answer you need in the user's guide, please visit the pepper.cbrpepper.org website and click on the Help/Contact Us button, then click on the Help Desk button. Complete the online form and a member of our staff will respond promptly to assist you. Please do not contact any other organizations for assistance with Pepper. Rely Group is contracted with CMS to support providers with obtaining and using Pepper. If you have questions, please contact us. We are the official source of information on Pepper. Please do not pay consultants to help you with Pepper. We provide support at no cost to you. And beware that not all consultants can provide accurate information on the Pepper. Again, please do not use the chat function to ask your question. If you use the Q&A function, I will be monitoring that as I finish up and I can answer any question that you might have. This is a screenshot of our website, and you can see the resources are easily accessed from the home page. In addition, we have an electronic feedback link on our website because our main goal is to provide information and reports that can be helpful in preventing improper payments. We are interested in your feedback and suggestions for improvement. We strive to make these reports as easy to use and interpret as possible, and we welcome your input. And also note the Help/Contact Us tab at the top. As we conclude, please take a minute to provide feedback and let me know if this webinar was helpful to you. As I end the session, the post-event survey will display in the window, and we appreciate feedback as we can use it to improve future sessions. Thank you so much for joining us today.